Terrence Jackson. I'm a hepatobiliary pancreatic surgical oncologist here at Northeast Georgia Health Systems. Today I have the pleasure of introducing one of our esteemed guests, Dr. Shravanti Macherla. She's a medical oncologist at Long Street Clinic, also part of our cancer center, and she's been spearheading our hepatic artery infusion pump program. Good morning, Dr. Macherla. Thank you for being with us.
Thank you for having me. My pleasure.
Today we have the pleasure of talking about hepatic artery infusion pumps. And even though it's new for us at our institution, this has been around for quite a while, and we have plenty of information on it. Would you care to tell us a little bit about what hepatic artery infusion pump therapy is and how it would help our patients, maybe?
Sure. So hepatic artery infusion pump is not experimental, and it's been there for at least 40 years of research by Dr. Nancy Kamini and her colleagues. So hepatic artery infusion pump is a device that is placed under your skin in the anterior abdominal wall, and it gives us the opportunity to deliver high doses of treatment, local treatment to liver tumors from metastatic colorectal cancer and also a type of biliary cancer called intrahepatic cholangiocarcinoma. So because it leverages HAI, that's what I'm going to call it, is it leverages on the unique anatomy of the liver and the properties of this drug called floxuridine, which is the chemotherapy, to achieve effective and safe concentrations of local treatment to these tumors, and thereby reducing the volume of the tumors and increasing the response rates.
That's right. And the unique anatomy of the liver that you mentioned is something to note, because the liver has two separate blood supplies. And in a traditional way, when we give chemotherapy through a port, the chemotherapy medicine goes through the liver, through the portal veins, and gets metabolized. And by the time it comes back through the arteries to the cancers in the liver, it is actually at a much lower concentration. So just like you said, giving chemotherapy through the hepatic artery infusion pump allows us to increase the concentration of floxuridine, FUDR, up to 200 to 400 times the concentration otherwise. Is that correct?
Correct. That's absolutely
and
right.
That you think is the basis of the response?
Basis of the response. And also what it does is, you brought up a very good point about the first pass metabolism, where the liver extracts the drug, up to 97% of the drug. So only a small amount of it is exposed elsewhere in the body. So major part of it, up to 200 to 400 times of the drug, is exposed to those tumors in the liver.
Wow.
Yeah.
Wow. Do you think that helps give us some of the quality of life benefit that we saw in some of the older studies as well?
Absolutely, because it's decreasing the systemic toxicity of the drug, thereby able to, tolerability is patients tolerate this drug better.
Yeah.
But of course, it comes with its own sort of side effects and complications that we'll talk about it in a little bit. Yes,
that's right. And we've had data on this for a very long time. As you mentioned, even in the 1980s, there are studies showing improved survival. And it wasn't until, I think, excuse me, wasn't until the 2000s when we started to have data on patients reaching surgery and a cancer-free status more often compared to with HAI compared to those who would just get port chemotherapy. Is that correct?
That's absolutely right. And I think, just for the audience, colorectal cancer is the third most common type of cancer in the world. Yes. And about 50% of patients will develop liver metastases during the course of their disease.
Yes.
Now, 20% of the people with liver metastases are upfront resectable.
Okay.
And surgery offers the best option to actually improve survival and possibly cure a small set of patients.
Yes.
Now, in addition to surgery, when you do systemic or IV chemotherapy, it may increase resectability by about 5 to 15%. But then HAI treatment, like you have mentioned in prior trials, has shown that it can increase resectability upwards to, I think, maybe 50 to 55%.
That's right.
Yeah.
That's right. And that is such a blessing in many of these patients, where they actually get a chance to be cancer-free.
Yeah.
And given the plethora of data that we have, we've had data from so far so far back. Why do you think it's taken so long for the community, our guidelines? Why do you think it's taken so long for everything to pick this up as part of standard of care? Any thoughts on that?
I think probably because there was also, when it started off in the 1980s,
Yeah.
it was a different medication, and, there's more fine tuning that has happened over the years
Yes.
with the pump and with the way we deliver the chemotherapy. So initially the toxicities were probably higher compared to what we see now.
Yes.
And then over a period of time, also the way we dose chemotherapy is based on liver function tests. And based on the liver function tests, we can alter the doses of chemo. Thereby, we are decreasing the toxicities of chemotherapy. And I think we've come a long way with the multidisciplinary approach.
Yes.
I think when that collaboration happens, we, not work in silos, but as a group,
Yes.
I think that definitely minimizes the risk and improves safety to patients. And also, I think it,
Yes.
that's how we improve care here.
And we are blessed here at Northeast Georgia Health System, where we have several extremely talented medical oncologists and a good surgical group, a wonderful hospital where we are able to provide this care. It was also around the 1980s and 1990s that the systemic therapy for colon cancer also changed. Is that correct?
Yes.
The EORTC trials had
Absolutely.
come out. And would you tell us a little bit about that? Because I feel like that made a huge difference in survival for these patients.
Correct. So I think systemic chemotherapy was started right around that time. The standard of care 5-FU that we use, base treatment, started around the 1980s, 1990s. Almost at the same time, HAI pump had come into picture.
Yes.
So I think that really changed how we treat colorectal cancer.
Okay.
And the initial complications of HAI treatment, I think a lot of centers probably did not follow through, and then it was easier to give IV chemotherapy, and that caught up. And I think now, in the past, I see probably 5 to 10 years, you see a lot more usage of,
Yes. Yes. And any thoughts on what downsides would be for patients who get HAI therapy? Certainly, HAI therapy is not a substitute for
Sure,
systemic therapy.
yes.
It has to be an adjunct. Any thoughts on what downsides patients could experience from
I
this?
think there are a set of patients that may not be great candidates. One is people with underlying intrinsic liver disease,
Yes.
like cirrhosis or portal thrombosis, portal vein hypertension.
Yes.
Those are people that, I think are not ideal candidates for HAI pump therapy.
Yes.
And also, if I think you can probably throw light on this better, is like any liver anatomy issues.
Yes.
Maybe that can be an issue too sometimes.
Of course, yeah. One of the downsides that we talk about to a patient when we discuss hepatic artery infusion pump therapy is that it requires an operation to have it placed. And it's not the biggest operation we do. However, it is a general anesthetic procedure, a rather complex procedure that we do robotically at our institution, thankfully. It also, the idea of using HAI therapy with systemic therapy also requires us to not have extrahepatic disease. So it alters their treatment paradigm in such a way that usually if they have a colon cancer or rectal malignancy with liver metastases, they would usually undergo a proctectomy, a colon operation first. At the same time, we would place the pump. So it alters their treatment pathway, and for some patients that can be a disincentive to go through this. And of course, some patients try to avoid surgery, in which case a pump is not possible to be placed. So I think the downsides of the pump, from my perspective, would be the need for a surgical implantation as compared to a port, which is much easily placed, and any complications or side effects that come from that. Granted, I will say, being able to place it robotically really allows for quick recovery in these patients. And in general, we place a pump, they are able to go home either the same day or they're able to go home the next day. And within the course of 2 weeks after the pump is placed, we confirm that the pump is perfusing the entire liver. And as long as that looks good, we are usually okay with starting systemic therapy. Pump therapy.
Pump therapy.
Would you tell us a little bit about what that looks like for the patient? How often do they get infusions through it? What do they experience? Please tell us.
So it's a small device that is actually placed on the anterior abdominal wall. And interesting, it's not run by a battery.
Yes.
Right, it's your own body heat that actually causes expansion of the outer part of this pump.
Yes.
And it applies positive pressure on the inner part where the chemo is instilled.
Yes.
And then the chemo is pushed out into this catheter, which is actually attached to the hepatic artery. And that's how it's delivered.
Yep.
So for the most part, patients, I think from a device standpoint, I don't think they experience there's probably just discomfort right after the placement, but there's no issues that I have seen so far. And so the way the medication, floxuridine, is installed is every 2 weeks, so you start chemo about 2 weeks after the placement of this pump. And then every 4 weeks, they get a dose of the chemotherapy. But every 2 weeks, they also need to get a heparinized saline filled in the pump.
Yes.
So it's always, there is something going in the
That's
pump,
correct.
right, to keep it patent. So that's how you kind of manage the pump, but you also base it on on your LFTs, that is your liver enzymes. If those are elevated, based on the protocols, you adjust the dosage of the pump, so thereby reducing the toxicities, because you're blasting the liver with all this high doses of chemotherapy.
Yes.
I think so. The liver toxicity is not as much, but this closely monitored.
Yes.
And the one toxicity that is commonly reported, not commonly, but up to 8% has been reported, is biliary toxicity. That means the bile duct itself, due to inflammation and irritation,
That's right.
you can have something called biliary sclerosis.
That's right.
And sometimes requiring a stent.
That's right. And, no therapy is perfect, and every one of them has their side effects. But when we look at the benefits that HAI therapy provides, 8% risk of some biliary sclerosis or complication seems like a manageable issue. And that is, as you mentioned, something we closely monitor and prevent.
Sure.
Don't we also use steroids along with our
Yes.
therapy in order to minimize these risks?
Absolutely. Steroids are used along with the chemotherapy to minimize the risks of specifically biliary sclerosis. I had a question. So if patients have undergone like ablation or histotripsy, are they still candidates for HAI therapy?
Absolutely.
And-
As long as the patient does not have extrahepatic disease and they have somewhat conventional hepatic arterial anatomy. Now, let me explain what that means. The goal of the hepatic artery infusion pump is for us to infuse chemo into it, and the chemotherapy slowly diffuses at the rate of about 1 milliliter per day throughout the liver. God makes everybody's livers differently, and some patients have an artery to the liver going to only one side, another artery going to another side. Those patients sometimes fall out of candidacy for HAI pump therapy, because ideally I would like to not infuse only one side of the liver. I would like to be treating all of it. And yes, so hepatic arterial anatomy plays a major role in whether they can be candidates or not. And we take great care as well about managing the bile ducts carefully, not dissecting too much around it. Because of the side effects of biliary sclerosis and cholangitis secondary to hepatic artery infusion pump therapy, every patient that undergoes a placement of the pump does require their gallbladder to come out, which would otherwise typically get infected, cholecystitis. And in those same lines, if someone has had a prior liver ablation or even a simultaneous liver ablation, they can still get the pump. We just have to monitor for infectious complications, but they are still candidates. And we're grateful to say, all of these options for the liver, they're usually not mutually exclusive. We mix and match and bring and select the best few options for these patients who are going through so much difficulty, so that they can hopefully get to a cancer-free status. And you brought up a very good point about how the pump works, and I've always found it very fascinating. It has inert gas within it, which expands and contracts with temperature. And because of this change in volume of the gas based on temperature and external pressure, we tell the patient, specifically not to do certain things after HAI pump placement. Would you like to talk about that?
Yeah, that's interesting. You know, patients, we tell them to avoid any overheating situations like spending time in a sauna, hot tubs, or
Yes.
long baths, and also just applying a heating pad on your abdomen.
Yes.
Because that sudden increase in temperature can deliver more doses,
That's right.
higher doses of chemotherapy in a short interval of time.
Mm-hmm.
You would like to, you want to avoid that. And also, I think altitude. I was reading
Yes.
about that. Is
Yes,
that can
external
change.
pressure.
Yeah.
So just like physics, when we
Yeah.
have more external pressure, gas contracts. When we have less internal pressure, gas expands. So when this gas expands, the rate of chemotherapy perfusion increases from 1 to approximately 1.5 or 2 milliliters per day. Still a small volume, but can have side effects. So while the patient is allowed to air travel, because they're in a pressurized container, we do have to request our patients not to go deep sea diving because that increases external pressure and therefore would increase infusion or perfusion of the systemic therapy. They're technically, if they go into outer space, that might be a problem as well. So I think they're not allowed to be astronauts. Yes, it's fascinating how the pump works, and it has gone through multiple iterations over the past 40 years, and finally we've come to a point where we are using a very inert, very stable, very well-functioning pump without any electronics within it. And it's about the size of a hockey puck. Have you had any patients complain about the size, and does that cause any problems to them?
I've not had any issues with. Yeah, it's pretty small, right? Like
About
it
this
is-
big. a
and it
hockey
weighs about
very
light. Yeah.
Very light. The weight is never a problem, I think. I definitely remember a patient who was an avid golfer, and they mentioned to me how it affected their swing because the pump was right about here. And as you mentioned, we do have every 2 weeks of maintenance. It's either an infusion of a systemic therapy, infusion of FUDR or heparinase saline. What do you think we do when we are done with the HI pump? And when are we done with HI pump therapy?
Right. I think about 6 cycles is standard.
Yes.
I mean, then you can reassess and see how, a patient is responding.
Yeah.
Now, you can leave the pump in, indefinitely.
That's right.
You just have to make sure that they get refills of this heparinase saline.
Correct.
Or an alternative to keep that pump patent.
That's right.
Yeah.
And the patients who are done with hepatic artery infusion pump therapy, as in either they are cancer-free or they're done with treatment, they do have the option of a glycerin infusion into it, which completely locks it. And they do have the option of getting the pump removed. Removing the pump is usually not as big a procedure. It can be done in the office. So overall, it seems like a very wonderful alternative, a wonderful adjunct to treatment for our patients. One thing I would say that it is a very resource-intensive treatment, and definitely takes a lot of resources on our side, where we have specialized nurses and coordinators that take care of their patients on the surgical aspect. Would you tell us about what resources you've been having to use on your side as well, please?
I want to emphasize on the importance of interdisciplinary approach.
Yes.
So I think, of course, our surgical colleagues, for us as medical oncologists, it's a very important collaboration, and also interventional radiology.
Yes.
Yes, and then oncology nursing. Because they have to be trained to administer this chemotherapy.
That's right.
Also, pharmacy. That's a huge, I think, they give us input about dosing and,
Yes.
altering, adjusting the dosing based on liver function tests. And also remember, these patients are on systemic chemotherapy. So you have toxicities related to that or side effects related to that. So we have to adjust our dosing based on everything that is happening at that time.
That's right. And particularly, I want to mention the role of interventional radiology. Like I mentioned, some people have alternate or aberrant hepatic arterial anatomy, some of which is not always diagnosed at the time of pump placement. So occasionally we will have a patient who would have the pump already placed, But then later on, we would find that there is an aberrant anatomy coming from the stomach going to the liver. And those patients will typically need that aberrant artery clotted
Sure.
so that there is no malperfusion, extrahepatic perfusion of the chemotherapy. And typically, this is one of the rarer complications from hepatic artery infusion pump therapy. If they have extrahepatic perfusion from the chemotherapy, it causes ulcers in the stomach, ulcers in the duodenum. All of these can be managed fairly easily without any big operations, but we make our best efforts and dot our I's and cross our T's, making sure this doesn't happen. And yes, infusion nurses play a major role because every 2 weeks these patients are on some type of treatment or the other. As we feel great about how we've been able to introduce this to our community and offer this option to our patients. Where do you see us going with this hepatic artery infusion pump program within the next maybe 1 to 3 years?
I think identifying the correct patient. So for that, I think awareness, education is important.
Yes.
So we identify the right patient, and we, so that they're, make sure they're candidates for HAI pump therapy, and they get the benefit out of this. So the more patients we treat, I think our experience in
Yes.
managing the pump
Yes.
will definitely improve. Our learning curve will definitely shorten. And I think our community, I think we are at a unique location, serving
Yes.
a large area of Northeast Georgia, so which has access to now HAI pump therapy in addition to histotripsy.
That's right.
So I think that's probably where I would see the future of HAI in this,
That's right. We're certainly poised. We're certainly poised to be able to manage very complex liver metastatic disease. With histotripsy, we are one of very few programs across the world that offer that therapy. Under the auspices of our studies, we are able to treat multiple liver metastatic lesions from a variety of primaries. And with HAI therapy, we certainly have a well-proven option for colon cancer liver metastases. How do you feel about using this for intrahepatic cholangiocarcinoma?
I have not had a lot of experience using it for intrahepatic cholangiocarcinoma. As you know, it's not a very common
Yes.
cancer. So, but I've seen the studies showing
Yes.
the improvement in survival
Yes.
based on it. Because I think the survival, the prognosis of intrahepatic cholangio is poor.
Yes.
It's about 3%, less than 3% at 3 years.
Yes.
And that has improved with the use of HAI pump therapy.
That's right.
Do you see any differences in terms of that patient population between colorectal and intrahepatic when, in terms of HAI pump therapy or?
I think the biggest difference we see is in terms of cachexia and performance status. Intrahepatic cholangiocarcinoma, as you mentioned, is a very aggressive disease, and unfortunately, despite all of our advances, we haven't found good systemic therapy for it yet. And I think when we find good systemic therapy for it, we will get better responses from the disease, and that would probably allow us to catch patients or allow patients to be at a better performance status. Usually, the biggest difference I've seen in patients with intrahepatic cholangiocarcinoma are how advanced the disease is at presentation, how much effect in terms of cachexia the disease has had on these patients. Anatomically, they're similar. However, my gut feeling is that they are at a slightly higher risk of biliary complications, since cholangiocarcinoma is a biliary disease and tends to cause biliary obstruction quite often. So those are my opinions on that, and I do feel like HAI therapy is a good adjunct for intrahepatic cholangiocarcinoma as well. Such a difficult disease to treat, and really any options we have is just a blessing.
That's true.
I am hoping over the next few years that we are able to offer HAI therapy. Now, this would be a boon for our community where we would be able to place the pump here. We would have expertise in medical oncology here, however, offer guidance to a separate group slightly far away, particularly for our patients that come from up in the mountains or very far away, and they don't have access to coming here. Do you think that would be feasible or at all possible within our community?
Sure. I think it's a possible, it's a possibility, but I think the limitations, I think it requires training,
Yes.
especially nursing,
Yes.
because it has to be administered, and they should have the sort of resources and infrastructure to be able to manage a pump, which I think is fairly simple once you're trained managing it.
That's correct.
So I think probably more awareness and training
Yes.
to the from oncology, nursing, pharmacy. But of course, if we are offering tele, I think we manage that part in terms of input regarding chemotherapy, dosing, management of with our pharmacy.
Yes, and hopefully we can get to that point. Regardless, I'm very grateful about where we are, and I'm grateful for your support and the rest of your team and all the hard work you've done to set up the medical oncology side of this, and I'm grateful for our team as well. Any other points of discussion, do you think, on HAI therapy?
First of all, thank you for having me and also including me in this group, being a part of HAI, therapy
No problem.
at Northeast Georgia.
My
So
pleasure.
Thank you.
No problem, no problem. And I would put a plug in for our group here. We have a wonderful medical oncology and surgical oncology group. We offer a variety of treatments for many different cancers, including cancers of the liver that come from elsewhere or that arise within the liver itself. If anyone has any questions about HAI therapy, histotripsy, please feel free to reach out to our team. We have dedicated pages on our websites for this. Thank you, Dr. Macherla, again, and have a good day, everyone. Thank you.